Good morning, everyone. Thanks for having me, and thanks to all of you for being here. As Darrow said, I'm an internist and an addiction medicine specialist, and have been so for a long time. But I never knew much about benzodiazepines until a few years ago when I started my functional medicine practice in addictions. Working in an inpatient detox facility, we followed the standard of care of benzo discontinuations. We admitted and tapered patients with a long-acting benzodiazepine. Our standard of care is a 5-day taper with diazepam. Then we send patients home or to a rehab facility with only supportive medications. It is certain that most patients relapsed once they could, but we don't know for sure since we do not follow them as our patients. When I started my addictions private practice, many patients came to see me for help tapering, and they stated that the medical establishment was not very helpful and sometimes even harmful for what they were needing to get off of these medications. With this presentation, I'm hoping to give you a deeper understanding of the many issues surrounding benzodiazepine use. This is a typical quote from a patient suffering from benzo use. Benzos are toxic in the long term, in my opinion. Once you're tolerant, they simply become normal. It's like you're not on a drug. They have such deep effects on emotion, on learning, and you only realize that once you're off of them. I was on them for about 4 years solid, but played with them prior. It's 4 years that are a black hole. I hate that I won't get it back. Benzos terrify me utterly. I'm hoping from this presentation, you will understand this person's cause of suffering. This is the outline of my presentation. Basically, we're going to do background and history, talk about harms. I'm going to do a case presentation, and I'm hoping we'll have some time for questions. There are about 15 different benzodiazepines that are approved for the use in the US. The most popular are alprazolam, clonazepam, diazepam, lorazepam, and chlordiazepoxide. Another class of medications are the so-called Z drugs because of the presence of the Z of a Z in their name. They're very similar to benzodiazepines, but are only approved for insomnia treatment. The hope was that they would have less side effects than the benzos, but in actual use, they have similar harmful effects as the benzodiazepines. Benzodiazepines are used to calm the brain down for symptoms such as anxiety, panic disorder, insomnia, seizures, agitation. You would be surprised to learn, just as I was when I first heard this, that benzodiazepines are recommended for use for only 2 to 4 weeks. There are many reasons for this. You will understand the reasons as I go through the presentation. Benzodiazepines were first discovered in the 1950s in a laboratory by Leo Sternbach. There was a lot of excitement with their discovery as they were thought to be safer and less toxic than barbiturates, but with the same anti-anxiety effects. Barbiturates were the medications that were used for anxiety since the 1920s, but the difference between a therapeutic dose and the lethal dose is narrow, leading to risks of fatal overdose with barbiturates. The first benzodiazepine discovered was chlordiazepoxide in 1955. It comes to market in 1960. Then in 1963, we have diazepam that comes into the market. It's 2.5 times more potent than chlordiazepoxide. Between 1969 and 1982, diazepam becomes the most prescribed drug in America. 2.3 billion tablets were sold just in 1978. The mechanism of action of benzodiazepines wasn't discovered until 1974. And in 1993, the first Z drug, zolpidem, becomes available. There were many consumer there were many direct-to-consumer advertisements that catapulted benzodiazepine use to the top. It was marketed to husbands to help their wives deal with house chores, and marketed to women to help in their interactions with their children. And chlordiazepoxide was marketed to therapists and counselors as a way of getting patients to open up and be more available during therapy session. Benzodiazepines modulate the GABA receptor. GABA stands for gamma aminobutyric acid. It is the main inhibitory neurotransmitter in the brain. So a bit of neurophysiology here. The purple figure here is the GABA receptor sitting in a cell membrane. There are 5 subunits that make up the receptor. The GABA attaches to one area on the GABA receptor, and the benzodiazepines attach to another area, and barbiturates to another one, and alcohol to another area. When GABA attaches to its receptor, it changes the configuration such that chloride ions pass into the cell. Once you have the negative chloride ion going into the cell becomes more negative. It hyperpolarizes the cell, preventing nerve transmissions from moving onwards. If you remember from way back in biochemistry and physiology, you need depolarization for cell action, meaning the cell has to become more positive. When the cell becomes more negative, when the chloride ions are going into the cell, it becomes harder for cell signals to pass through. Less nerve-to-nerve signaling is what gives the calming effect. So when benzodiazepine attaches to the GABA receptor, you have more of the chloride ions passing through, causing an even more depressant activity in the brain. So GABA connections are found throughout the brain, mostly as interneurons in between other neurons, modulating the effect of all the neurotransmitters. Chronic administration of benzodiazepine leads to a negative feedback in the brain. Glutamate is the main excitatory neurotransmitter, and we just talked about GABA being the main inhibitory neurotransmitter. You need glutamate in the right amount for good attention span, brain energy, learning, and memory. Glutamate can mitigate the effect of GABA. When you give benzodiazepines for some period of time, it causes a change in the balance of neurotransmitters. As mentioned earlier, benzodiazepine increase the GABA depressant effect, the downward green arrow. When the brain sees a lot of GABA, it says, whoa, that's too much inhibition. So it tries to create balance by pushing up the excitatory neurotransmitters and decreasing the number of GABA receptors and decreasing the amount of GABA neurotransmitter that's released. So when you stop the benzodiazepine abruptly, you may have the symptomatic effect of the increased excitatory neurotransmitters, and you don't have enough of the receptors and the GABA to modulate that. So that's why you may have increased agitation or anxiety. GABA and glutamate are the 2 most prominent neurotransmitters in the brain. The wheel gives you a rough idea of the proportion of different neurotransmitters. The brain and body is always looking for homeostasis to achieve an optimal balance between GABA and glutamate and all the other neurotransmitters. So when you give an individual benzodiazepine, the brain is out of optimal homeostasis. The brain will adjust to the effect of too much depressant activity by neuroadaptation, decreasing endogenous GABA, downregulation of GABA-A receptors, and a cumulative decrease in inhibitory impulses and increase in the excitatory impulses. One of the curiosities of evolution is that GABA is synthesized from glutamate. So glutamate, in effect, creates its opposition. GABA's existence depends on adequate glutamate. The most prevalent inhibitory neurotransmitter in the brain is made from the most common excitatory neurotransmitter. To make adequate amounts of GABA, you need glutamate, you need vitamin B6, and the glutamate decarboxylase enzyme. If you have a deficiency of either B6 or GAD enzyme is not working well, you may not be able to make enough GABA. GABA is recycled via the Krebs or the citric acid cycle, which takes place within the mitochondria. And for de novo synthesis of both glutamate and GABA, you need to start with glutamine. And that process takes place in the astrocyte. In other words, to have adequate GABA, you need vitamin B6, you need glutamate decarboxylase, you need adequate glutamate, you need adequate functioning of the citric acid cycle, and therefore the mitochondria, and you need a functional astrocyte. So it's important to know the synthesis and metabolism of GABA so that you can understand the effects of benzodiazepine use. Again, benzodiazepine affects the GABA receptor. Let's move on to some statistics. Benzodiazepines are widely prescribed in the US. A national survey conducted in 2015-2016 showed that 30.5 million adults, or 12.6% of the population, reported past year use of benzodiazepines. Between 5 to 10% of US adults are actually prescribed benzodiazepines. Adults in the age group of 50 to 64 had the highest prescribed use at 12.9%. In 2013, 13.5 million US adults filled a benzo prescription. And 2019, 92 million prescriptions were dispensed. So almost all the benzos used are prescribed. So benzodiazepine use in the US is common and increases with age. Currently, there are 7 benzo and Z drugs that are among the top 200 most prescribed medications in the US. This slide shows that with increasing age, you have a higher percent of use. This is data from 2008. Age is on the x-axis, and on the y-axis is percent use. You can see the percent use, again, is increase as the ages increase. So the percent use steadily increases over the lifetime. This survey just looked at visits where benzodiazepines were prescribed in a primary care setting. The x-axis is age group, and y-axis is the annual benzo visits per 1,000 population. You can see that the number of visits, again, is increasing by age groups. The light gray is new prescriptions, and the darker gray reflects renewals. The rate of new benzodiazepine visits is relatively constant across the age groups. But what is increasing is the overall number of visits for renewals. So it seems that once a prescription is written, renewals are done. So why are medications being refilled? As we discussed earlier, it is recommended that we use benzos only for 2 to 4 weeks. Yet, this data shows that there are many patients who are getting continuations of medications for longer than 4 weeks, some for years and some for decades. When we look at the effectiveness of benzodiazepines, we note that the duration of effectiveness is short-lived. There are not many randomized control studies of long duration done, But when you do look at the literature on the effectiveness of the medications for the symptoms for which they were prescribed, studies show that the sedative effect is lost within a few days, and the anti-anxiety effect is lost within a few months. And in many studies, compared to placebo, there's actually no benefit. Most research is sponsored by pharma, and they only conduct and publish studies of short duration, the longest here being 4 months. So then why are benzos being renewed and continue to be prescribed for years? It might be the case of, if it ain't broke, don't fix it. In other words, the patient may not be having any problems, and in fact, they may think it's helping them, and so the prescriptions are renewed. Or it might be because some of those patients may have experienced withdrawal symptoms when they missed or delayed taking the medication. So they continue to use the medication either consciously or unconsciously to avoid these symptoms, which would indicate the development of physiologic dependence. There are two characteristics of physiological dependence: tolerance and presence of withdrawal symptoms. Withdrawal symptoms can happen when the dose of the drug is decreased or discontinued. They're related to the neuroadaptive changes that we discussed earlier. Withdrawal symptoms may be present in up to 40 to 80% of patients who are trying to stop. This may make it difficult for the patient who has been using benzos chronically to discontinue the use. Tolerance is another effect of neuroadaptation that may affect some individuals. When tolerance happens, the individual may need more of the drug to get the same effect. Some patients who experience withdrawal symptoms while taking the prescribed doses may ask their provider for a higher dose of medications. Other patients may experience interdose withdrawal symptoms. They may have symptoms in between their prescribed doses. For instance, if diazepam is prescribed twice a day, 8 a.m. and 8 p.m., they may have symptoms at 6 p.m. and so may request the provider to increase the dose. Some providers may mischaracterize these requests for a change in dosing or increased dosing as drug seeking, or that the patient has an addiction and ignore the patient request. As you can imagine, this can create tensions in the patient-provider relationship and suffering for the patient. So the patient is asking for medications because of physiologic dependence, because you're experiencing withdrawal symptoms. It's not necessarily because they're trying to get high or that they're trying to misuse the medications. So these are the withdrawal symptoms that most patients may have: anxiety, irritability, panic, insomnia. And withdrawal symptoms should last for less than 30 days, the amount of time it takes for the medication to actually leave the body. There are about 10 to 20% of patients who have a prolonged withdrawal syndrome that we'll talk about shortly. Benzos are not like antibiotics. With an antibiotic, you take it, it cures the infection, and you can stop. But with benzos, what you're really doing is you're suppressing the symptoms and may not be really addressing the underlying issue. Again, often people mistake the presence of withdrawal symptoms as being a sign of addiction. It's clear that physiologic dependence is different from addictions, and it's very important that we make the distinction as we're treating these patients. This is the same survey that we saw earlier. In that survey, where they found that 30.5 million adults used benzodiazepines, they found that only 0.2% met the criteria for a substance use disorder. And of the 30 million, there are 5.2 million adults who misused the benzodiazepines. So this and other surveys show that very, very few benzo users met the criteria for substance use disorder, basically 0.2%. And for the patients who misused, and misused is defined as not taking the medication exactly as prescribed. 69% used it to relax or relieve tension and to help them with sleep. Less than 12% who misused it used the benzodiazepines to get high. So let's spend a couple of minutes on this slide. These 11 criteria make up the definition for addiction. This is the new DSM-5 that came out in 2013. These criteria encompass continued use of the drug in spite of negative consequences and craving. When the new DSM criteria for SUD came out, they made clear that if you only had tolerance and physical dependence, that's criteria 10 and 11, you are excluded from having the diagnosis of an SUD. So even with the new DSM criteria, benzo tolerance and withdrawal symptoms does not give you a diagnosis of addiction. But you can think of it in another way. Essentially, addictions is about the effect on the dopamine neurotransmitters and the reward pathway. Criteria 10 and 11 can be true of any psychotropic medication like the SSRIs. So if an individual is taking benzodiazepines as prescribed, they may experience physiologic effects of tolerance and withdrawal, but this would not cause the individual to meet the criteria for an SUD without additional symptoms from 1 to 9 also being present. Earlier this year, JAMA published this article also clarifying that benzo physical dependence does not constitute a DSM-5 criteria for use disorder. They proposed a new name, complex persistent benzodependence. We have overwhelming evidence not to classify benzodependence as an addiction. Again, this distinction is important because of our current model of treating patients with addictions. And here it is. So when a patient needs to discontinue from benzodiazepines, there are two ways you can do it. The current model, if you diagnose a patient as having an addiction or a substance use disorder, the current model is to do a rapid detox with a long-acting benzo over 5 to 10 days. And then you send the patient either home or to rehab, which is an inpatient setting for 14 days to several months, usually medication-free. But if you can diagnose the patient as having benzodependence, and this is the preferred model, and this diagnosis is supported by the FDA, patient support groups, benzo advocacy groups, and the DSM-5 criteria, you can do an outpatient, slow, patient-controlled benzo tapering over months to years. And this is really the preferable way to get a patient off of benzodiazepines. The FDA recognized the dangers of our current model of rapid detox and taper. So they came out with this black box warning in 2020, stating that no benzodiazepine tapering schedule is suitable for all patients. Therefore, we need to create a patient-specific plan to gradually reduce the dosage, not our current model of 5 to 10-day rapid tapers. This is the manual that you or your patient can use for benzo tapering guidance. Let's see, sorry, trying to adjust my screen. You can get free online copies of this at the website indicated. Professor Ashton, who recognized the dangers of benzos in the late 70s to 80s, She wrote several research papers, and from 1982 to 1994, she ran a benzodiazepine withdrawal clinic in the UK. In 1999, she published this book called Benzodiazepines, How They Work and How to Withdraw, based on her experiences with thousands of patients. It is now simply known as the Ashton Manual. This informal survey from a harm reduction site noted that among the respondents, they said that benzodiazepines were the worst drug to withdraw from. I hope you now understand why the individuals would say that. It's because of the way we are currently treating patients who request benzodiazepine discontinuations with a rapid taper over a short period of time, rather than the slow discontinuation that is being recommended. This slow tapering should happen over months to years to give the brain and body enough time to heal from the neuroadaptations that had taken place. For about 10 to 20% of patients who've been taking benzodiazepines for some period of time, they may experience a protracted benzo withdrawal syndrome. This refers to symptoms that are present for more than 30 days. These are the effects from longer-lasting changes in the brain. Patients are suffering from a myriad of symptoms that can last from weeks to years. They can have symptoms such as agoraphobia, paranoia, new obsessions, smell, speech, and taste alterations, somatic complaints resembling heart attacks or GI distress. This list is not complete. There are many more symptoms listed on the website here. These symptoms could be from neurotoxicity and or neuroadaptive changes from long-term benzo use. From a functional medicine root cause point of view, I suspect that it's the interplay of the individual's genetics, epigenetics with environmental factors, such as nutrient deficiencies, endocrine issues, benzo effects on the gut microbiome, inflammation, and oxidative stress causing these changes in the brain. A survey was undertaken to get a better understanding of the effects of benzodiazepines on individuals with this prolonged withdrawal syndrome. This survey was done between 2018 and 2019. There were about 1,000 respondents from 16 internet sites, and 23 physical symptoms and life domains were evaluated. The aim of the online survey was to document the personal experiences of a convenient sample of individuals who had used benzodiazepines, including those either currently taking it, those who had tapered off, and those in the process of tapering. What they found, and they were only looking for 23 symptoms, what they found was that many patients had many symptoms that lasted for several years. Here you can see that low energy was present in about 88% of patients, and 51% had that particular symptom lasting for many years. Nervousness, anxiety, and fear, those symptoms were present in 89% of the respondents. 50% of them lasted for many years. Same thing for sleep disturbances, memory loss. Many of these symptoms were lasting many, many years. In addition, many respondents, about a third, 31.5%, reported new food allergies and or seasonal allergies that occurred only after benzodiazepine use, and 18% reported being diagnosed with a new autoimmune disorder. So these new allergies and autoimmune could be due to gut microbiome changes with the benzos. So not only do these patients have symptoms noted, it also affected many aspects of their life. It affected their marriage, and many patients, 50%, had either suicidal thoughts or actually attempted suicide. So you can see that benzodiazepines, for the fraction 10 to 20% of those who use it chronically, has significant effects in their life. And this is how some of them express their issue. One patient said, if I could think of the one possible thing you could do to a person, it would be benzo withdrawal. Beats cancer and Alzheimer's combined. If I could make it go away by chopping my arms and legs off, I would. Another individual said, benzos ruined my life. I have been benzo-free for 2 years and still in protracted withdrawal. My doctor cut me off without warning. I believe doctors who do this should lose their license. I went to the emergency room within days of being discontinued and was locked down in a mental health unit for 9 days with no treatment except coloring in a room full of dangerous patients. Again, all of this indicating the profound disruption of benzodiazepine use in these patients' lives. So to give a name for the persistence and the depth and breadth of the disruption of benzodiazepine use for a certain number of patients, these 3 advocacy groups came up with a new name. It's called benzodiazepine-induced neurologic dysfunction. This just came out this year. BIND is a constellation of functionally limiting neurologic symptoms, both physical and psychological, that are the consequence of neuroadaptation and or neurotoxicity to benzodiazepine exposure. These symptoms may begin while taking or tapering benzos and can persist for weeks, months, or even years, even after discontinuation. So these were the names that we're all trying to use to give a name to what the patients were experiencing. So there are many harms related to benzo use. Here I've listed a few. If you go to the references, you can read about many more. We have already discussed physiologic dependence and addiction and the problems with labeling patients with benzo use as having an addiction. We talked about protracted withdrawal or bind. I'm going to talk about overdose deaths when combined with opioids, and I'm going to talk about cognitive impairment. But there are many more here, like motor vehicle accidents, falls and fractures, increased risk of infections, emotional blunting, insomnia, worsened insomnia, and problems in the fetus to the unborn with use in pregnancy. So this might be the reason you may consider discontinuing a patient from benzodiazepine use. Okay, so the blue bar here shows the number of overdose deaths involving benzos between 2002 and 2015. The red line are those that also were using opioids. So the blue line is deaths involving benzodiazepine use. The red line indicates those who are using both benzos and opioids. So you can see almost 90% of people who died involving benzodiazepines also had opioids. Benzodiazepines by themselves is infrequently the sole cause of death. You can see the purple line, it's pretty much steady over the 13 years, even though the number of prescriptions that were dispensed were much more, and there were many more people using it for longer periods of time. So if you have a patient that's getting both benzodiazepine and an opioid, you would give that patient Narcan or naloxone so that in case they overdose, their family member or friend can administer it to them to overcome the effect of the opioid. So you really need to warn the patients who are being co-prescribed benzos and opioids, and there are 10%, as I said. So they need to be warned about the risk of overdose. This is another harm that I'm going to discuss now, which is that chronic use of benzodiazepine is suspected to increase the risk of cognitive impairment and dementia. This is one of the main reasons individuals want to discontinue benzo use. This study was published earlier this year and showed a mechanism by which diazepam use can cause dysfunction, cognitive dysfunction in mice, not in humans, in mice. So as I mentioned earlier, we have different kinds of brain cells. We have neurons. We mentioned astrocytes earlier when we were discussing de novo synthesis of GABA. Here, we have the involvement of another kind of brain cell called the microglial cell. Microglia screen their microenvironment and get rid of dysfunctional neurons. Diazepam, a benzodiazepine, binds to and increases the TSPO protein levels in microglial cells. So the TSPO receptor is found in the outer mitochondrial membrane of the microglial cell. So this is a different receptor than the usual one that benzos bind to, which is the GABA receptor. Here they're binding to a receptor called TSPO in the microglial cell. So the binding of diazepam causes an increase in TSPO protein levels, which in turn causes longer and more branch points developing in the microglial cell. And they also have increased complement expression. These longer microglial processes with the complement induces phagocytosis of the dendritic spines. And loss of dendritic spines has been shown to lead to cognitive dysfunction. So on the right-hand side, you can see a neuron, the one with the long tail, and then you can see microglial cells, a little darker shade of blue. So those microglial cells usually are responsible for screening and maintaining the environment around them. When the TSPO, when diazepam sits on the TSPO receptor, there's more of these processes that come out of these microglial cells, and they go and they basically eat up the dendrites of the neurons. They phagocytize the dendrites, and decreased dendrites mean an increase in cognitive dysfunction. This is all just in mice. We think this might be the same process of how benzos cause cognitive impairment in humans. Really interesting stuff. All right, so this is the workflow you could use with your patients whom you're considering for benzo discontinuation. Anyway, so if a patient is not on a benzo, and if you're considering starting them on a benzodiazepine, don't. Look for alternative treatments. But if you and the patient decide that the patient should get the benzo, have the patient sign an informed consent with risks and benefits explained. Then prescribe the benzo only for about 2 to 4 weeks and have them take it intermittently. If they are on a benzo, and if you think the patient's symptoms are coming from the benzo, then you could discuss with the patient the need for a taper. Because once they come off the benzos, there's more of a chance that the symptoms would go away. If the patient is stable and doesn't have any symptoms, you could still talk to the patient about the long-term effects from benzodiazepine use. And we talked about them, the physiologic dependence, the chance for prolonged withdrawal due to neurotoxicity, the overdose risk if combined with opioids, the risk of cognitive dysfunction, falls, fractures, motor vehicle accidents. So even if they don't have any symptoms, you could start talking to them about some of these long-term effects. If the patients in both scenarios agree to the tapering process, you could use the Ashton manual as a guide. But know that the tapering schedule in that guide might be too rapid for some, and you may not need to use diazepam, because in the manual, she recommends using diazepam. So you can use the Ashton manual as a guide. You can recommend testing for nutrient deficiencies, gut microbiome, and maybe food allergy testing. Definitely encourage lifestyle changes with a good diet, meaning low glycemic index, high protein, low fat, high fat, low carb. Encourage movement and really be cautious with supplements with these patients. They're very, very, very sensitive to supplements. So I'm very cautious with them. And then, as I mentioned before, not everyone needs to switch to diazepam. You could taper the patient with whatever benzodiazepine that they're currently on. Again, that's something that you need to discuss with the patient and really understand how to do that. Then you would do a very slow taper. So we're talking about 2.5% to 5% per week or per 2 weeks. That's how slow you need to go in decreasing the dose. And you would do a patient control. So the patient would control the taper and you could guide them in the tapering process. And so tapering would take months to years. And the patient will definitely need support of therapists and family. And here are the references for the previous slide. I had a lot of numbers there, so you can get more information from these websites. And you can get an informed consent from these two websites if you were thinking about starting someone on benzodiazepines. And we talked about the Ashton Manual and how it could help you understand what needs to be done in the tapering process. So we're going to talk about a patient of mine. Mr. John is a 50-year-old male who works as a concierge. At the start of the COVID pandemic, he became very worried about getting infected, about dying, and noticing his stress. Someone in the building gave him lorazepam. This worked. It made him feel better. So eventually he was able to get the same prescription from his primary care doc without any difficulty. No consent form was signed. After he received the second dose of vaccine about 6 to 8 months later, he felt much relieved and the stress of the unknown was gone, and he stopped the lorazepam. No one had warned him about the harms of stopping it abruptly. Within a few days, he was in the ER with heart palpitations, increased anxiety, weird sensations in the body, feeling tense and tingling. In the ER, he ruled out for a heart attack and stroke and sent home. After a few repeated visits to the ER, it was realized that his symptoms could be due to stopping the lorazepam. He was sent to outpatient detox. There, he was started on clonazepam, and he tapered off within 7 days. They tapered him off within 7 days. He was given some psychotropics for symptom control. He was discharged with these medications, but he did not feel good, and he continued with repeat ER visits. Because of these repeated visits, they then referred him to an inpatient facility where he stayed for 30 days. There, they did a rapid taper with chlordiazepoxide. Again, he did not feel good after discharge in spite of adjunct medications. Once he got home, he restarted the lorazepam that he had left. And he went to the internet to learn about the effects of this medication. By the time he found me, he had read the Ashton Manual and was part of several online support groups. His only history was medical history was high blood pressure. He had a history of childhood trauma for which he was seeing a therapist. And he had a very supportive wife and daughter who was living with him. Again, very educated on the effects of benzos. He was pretty much following a clean diet. He was actually organic, low sugar, high protein, fat diet. And he completed several questionnaires with me, and we'll go through each of them. Pyroluria, I felt he did not have pyroluria. We did a neurotransmitter depletion chart, and we evaluated for hypoglycemia with the diet diary. I also check for adverse childhood experiences with each patient. I don't address it, but I just check for it in the beginning. And I would address it later on, but he was already seeing a therapist. So pyroluria. So pyroluria is thought to be mostly a genetic epigenetic condition that leads to an increase in pyrroles in the urine. You can also find this in individuals with stress or gut microbiome issues. I think many patients on benzodiazepines may have pyroluria. This is just a suspicion. There have been no studies. Pyroluria is not recognized as an ICD-10 diagnosis. It may be that many patients had been prescribed benzodiazepine for the anxiety that you may get when you have pyroluria. So pyrroles are the natural part of the degradation of the heme molecule, heme from hemoglobin. These pyrroles, these degradation products we find normally, most of us have a little bit, but those with either this genetic issue or the gut microbiome issue or stress, they have more pyrroles than normal. These pyrroles bind to zinc and B6, and they're taken out of the body in the urine. So the body has depleted levels of B6 and zinc. So the way you diagnose it is with a questionnaire and a urine pyrroles test. There are many questionnaires out there. This one that you see filled out on the right-hand side is by Trudy Scott. And I'll show you another one in the afternoon lecture that I'm doing with Dr. Zawicki. So basically the questions are about social anxiety and B6 and zinc deficiency. This patient did not give many positive answers to the questions, so I did not think he had pyroluria. But in general, the treatment for pyroluria is B6, zinc, and a few other nutrients. We'll talk more about this afternoon in this afternoon's presentation. So hypoglycemia is low blood sugar, defined as somewhere between below 70. In some places, it's 54. Some people define it as under 60. It depends on which organization is defining the hypoglycemia. There are no studies that document hypoglycemia in benzo use or in benzo withdrawal, but many of the symptoms of benzo withdrawal are similar to those of hypoglycemia, such as anxiety, panic, insomnia. And we know that the American diet has changed over the last several decades, and we're seeing more glucose dysregulation with increased diabetes. Hypoglycemia is usually hidden, and it usually happens a decade or two before the diagnosis of diabetes or prediabetes, where there's more insulin resistance and beta cell dysfunction. You need to do a 5 to 6 hour oral glucose tolerance test to really rule out hypoglycemia. This is a paper from 1966. So at that time, the standard American diet was much better. It wasn't carb-filled as it is now. In this paper, he found that many individuals were diagnosed with a neuropsychiatric illness when in reality, hypoglycemia was the root cause. The author states that many patients who had proven hypoglycemia with OGTT were being treated with sedatives and tranquilizers for their symptoms, indicating that they may have been diagnosed with anxiety and so being treated at that time with barbiturates, when in reality, they may have had hypoglycemia. This author did a 6-hour glucose tolerance test on all these patients. So he did the test in 300 patients. And what he found was that 60% of these patients with hypoglycemia had depression. Another 50% had insomnia, 50% with anxiety, 45% with irritability. As you can see, many of these symptoms are similar to benzo withdrawal symptoms. In addition, the author mentions a study from the 1950s where they looked at 275 consecutive patients who were seen in a neuropsychiatric practice over a period of 15 months. 31% of these patients were found to have relative hypoglycemia, with another 8% with a potential relative hypoglycemia. So basically, they were being referred for either neurologic or psychiatric diagnoses, when in fact, they had a medical issue. They had an issue of hypoglycemia. So you can see how many patients with hypoglycemia undiagnosed could be being diagnosed with all of these neurologic and psychiatric problems. So hypoglycemia is probably something that we need to deal with in our patients who are undergoing benzodiazepine withdrawal. Almost all the patients that I've seen so far in need of benzo tapering or undergoing benzo tapering have had neurotransmitter depletions. And this is how I evaluate for neurotransmitter depletions is through this amino acid chart. And we'll talk more about it later on this afternoon and tomorrow morning. Basically, we evaluate for four different neurotransmitters and hypoglycemia using this chart. The patients score between 1 and 10, between 0 and 10, the symptoms they may be experiencing. Then we give them different amino acids to boost up the neurotransmitter that might be depleted, that's causing those symptoms. Anyway, we'll talk more about it. So basically what we're doing is we're repleting any neurotransmitter deficiencies with amino acids. But as I said before, we have to be very, very cautious with patients who are undergoing tapering or withdrawal with benzodiazepine because you're very, very sensitive. So I would not give amino acids or supplements just very casually. So in my first visit with this patient, he said his goal was to taper off of lorazepam and return to work. So I started these nutrients, but again, please do not use these same nutrients for your patients in case you want to do your own taper. This really should be individualized. Then he was following pretty much a clean diet, so I asked him to continue, and I ordered a lot of functional medicine testing and some routine labs. So 1 week after I first saw him with those supplements that I just showed you, he said he felt better, miraculously. I'm not sure. Anyway, he wanted to start the diazepam substitution protocol per the Ashton manual. He was on lorazepam 3.5 milligrams. So the equivalency is 35 milligrams of diazepam. So he did the conversion over the next few weeks, and the way to do it is described in the Ashton manual. And he, like most patients, want to follow the Ashton manual. And so they pretty much use that as the Bible. So we continued and adjusted the supplements as needed. And at the 6-week follow-up, he told me that the crossover to diazepam was very difficult for him. He became extremely depressed, didn't have any energy. He had crying spells. And also what he had done is because he was having some interdose withdrawal, meaning symptoms in between his dosing, he increased the frequency of dosing. He was taking it 3 times a day to 5 times a day. Same overall daily dose. But anyway, he later regretted this move. So let me show you his labs. So this nutrient panel labs showed that he had very low vitamin B6. So these are different ways of indirectly measuring vitamin B6. And here, this showed that he had low antioxidants. So basically low CoQ10, vitamin A, beta carotene, and a high detox marker. And these are neurotransmitter metabolites, and all of those were low, indicating low serotonin, low dopamine, and low norepinephrine. And epinephrine. I was surprised that these are the mitochondrial markers, and I was surprised that they looked as good as they did. I thought they would be that they would all be low. It looks like just one of them are low. And I know I'm going pretty fast, but I'm trying to see if we have time for questions. These are some of the supplements that he was taking. Again, please do not use these supplements with your patients. And these are based on what his needs were, what he read on the internet, and some of his testing. I also did a cortisol test. As you can see, it was pretty low, but he did not tolerate any hormones. So please do not give any hormones to any of your patients. They just don't do well. And he slowly started to feel better. As I said before, we trialed different supplements depending on symptoms, results of testing, and his internet research. 2 months after his first visit with me, he completed the switch over to diazepam. Insomnia remains his biggest issue. He uses some medications, and his diet is great. He has frequent follow-ups with different people, therapists, coaches, and he does a lot of independent reading. 3.5 months, 3.5 months after his first visit with me, he went back to work, and he continues to taper with diazepam. He occasionally has setbacks with anxiety or insomnia. He became COVID positive, but he did very well with that. So here are lots of awesome resources for you and your patients. And thank you for listening.